It's estimated that nearly £300 billion could be saved worldwide if we improved adherence to medicines, and that's a really startling figure. I'm Delyth James, and I'm a Professor of Health Psychology in Pharmacy Practice here in the Cardiff School of Sport and Health Sciences. My inaugural lecture was entitled Mixing Psychology and Pharmacy, a Solution for Everything. I'm a registered pharmacist, registered many years ago, so I have experience of working in hospital pharmacy, in community pharmacy, in primary care, in pharmaceutical industry, lots of different sectors of the profession. And so with that, I think you bring a lot of the real world problems to the academic role. And in particular, of course, for me, it's how people take or decide not to take medication. Okay, bear with me 1 second. It used to be a very paternalistic approach in medicine, didn't it? Do what you're told, what you're prescribed, and people wouldn't necessarily question it. But certainly it's changed with the advent of Googling and being access to information. The person prescribed the medication plays an active role in that decision whether to take the medicine or not. And so it's really important that we provide evidence on why it's going to work, what it does, the reasons for taking it, and sharing any concerns, discussing any concerns around taking that as well. But there is this underlying distrust of the big pharma, and that seems to come through consistently, and that's something I think that we need to tackle. The role of the media, I mean, for every story we've seen about statins saving lives, you'll have one about statins causing side effects and long-term problems. So I can completely understand why it's really confusing for people out there. And if you've got access to someone who can help you interpret the information you're getting from Google or your medicine pack information leaflet, for you, that's really the central theme in all of this. Adherence can relate to any type of behaviour that is going to help you either recover from an illness or prevent illness. So in terms of medication taking, the extent of non-adherence is huge. It's been proven again and again that something between 30 and 50% of patients don't take their medicines as prescribed. That has a huge knock-on effect on waste of medication. And the figures are startling. It obviously means that people are not getting the benefit or getting better. So there's lots of potential problems with people not taking medicines and those knock-on effects, which clearly have a huge effect on cost and waste for the NHS. It's estimated that nearly £300 billion could be saved worldwide if we improved adherence to medicines, and that's a really startling figure. If you think about the amount of effort and resource and time and energy that goes into developing a new medicine, from the pharmaceutical industry, the investment into research and development, and it's huge. And then for it not to be taken by the patient, that one endpoint behaviour, we really need to invest a lot more into that process and understanding patients throughout that process, not just at the end or leaving it to the pharmacist or to the GP or the prescriber to pick up on that. This research is really important because if you want to develop interventions or solutions to real world problems, you need to understand the factors that contribute to it. So that was very much the premise of my inaugural lecture, and I gave some examples from my PhD research, looking at how patients who'd had a heart attack made sense of their heart attack and how that influenced their medication taking over the course of a year. Then the key things around what drives people to take medication or not to take their medication, and then how we wanted to take that into the training of pharmacists to make sure that they were addressing those things. Also some of the key terms to use with patients, so it's not just about this intervention, it's about the language as well, or how you build it into a conversation. Discovering the role of art and design in co-production and how we could work together. That's been a really important piece of work. We can apply the visualization in terms of communication to a lot of different areas, and the development of something called the Vista BP, visualising treatment to support adherence to medicines in high blood pressure. And this is a little animation platform that we've designed to try and help people understand what the numbers mean, systolic, diastolic blood pressure, how that has an effect on the artery, and when they take medicines, how it reduces the blood pressure, and then how that mitigates the effect of high blood pressure causing a stroke, and the visual of how that would cause a stroke in the brain. So this is where using psychological frameworks and theories has been so helpful in helping us to understand the nature of the problem, the reasons for the problem. It's a very applied area of research, and one that hopefully makes a difference. The research very much informs practice, whether that's training of pharmacy professionals or healthcare professionals, how we talk to patients or talk with patients about medication, and also trying to develop tools, materials to support people get a better understanding of their medication. If you look at a problem through one lens, you're going to get a solution through one lens, aren't you? So the more disciplines that you can bring around the table around the problem, the more likely you are to get the solution from different perspectives. Human behaviour is complex. That's why there's no one solution to things. And we work in complex environments and complex systems. And medicine is one small part within a very complex system. That small medicine that you're given, there's a lot of different things that go into that process. And so understanding that, I think, is really key.